We are so glad that you're able to join us. Welcome to the Health Equity and Racial Justice Breakout session. We are happy to have at this year's State of Public Health our presenters, Nadia, Siddiqui, and Dennis Andrulis. If you need any assistance during this session, please send a direct message to Carmelita Marrow using the Zoom chat feature. I will now turn it over to our presenters to start the session. Thank you all for joining.
Good morning, all. My name's Dennis Andrulis, and my colleague Nadia Siddiqui and I have been steeped in this project that we'll talk to you about. It's become to us more than a project. I would say it's been a life dedication for at least 4 years. First of all, though, before I proceed, I want to say welcome to our session, and also let you know that I must say from Remove in Texas that the song Georgia on My Mind has been kind of resonating over and over and over again with us in Texas. So as for all you've done and all you've been through, it's been quite amazing to watch. So we're happy to at least be virtual in this presentation and opportunity to connect with you. So the title of our presentation, Moving Beyond the Status Quo and Advancing Health Equity in Georgia, How Hope Initiative Informs Action, really embodies what this project has been about and what much of the work that we've been conducting at the Texas Health Institute has been about for as long as I can remember, actually. Next slide, Nadia. So about the Texas Health Institute, just briefly, it's an independent, nonprofit, nonpartisan public health institute in Texas, and focuses on healthy people and healthy communities. And the mission is broad to advance the health of all, although we also look at those who may be most vulnerable within Texas. And the work, while Texas focused, really has state and national, beyond the state and national implications. And much of the work has been national, as has this project that we'll talk about today, although we have the capacity within the project to focus specifically on states, as you'll see. Next slide, please. So in this presentation, we will discuss what health equity is. We'll present our perspective, as there are many perspectives on this, that phrase health equity. What is the HOPE initiative and what does it measure? What does HOPE tell us about Georgia, as we're able to kind of, describe and portray by our measures, by our focus, our framework, select the state of Georgia, and give you a little perspective of what, from our information and our work, it says about your state. And then finally, how can HOPE's findings be used to advance action? Next slide, please. So there are many descriptions of health equity. Paul Braveman has been someone who we've worked with and has actually been a member of our advisory group. And we have worked with her and used her description and definition of health equity actually in conjunction with our support of the Robert Wood Johnson Foundation to describe it as an effort that removes obstacles to health, including poverty, discrimination, consequences, addresses powerlessness, lack of access to good jobs, fair, quality education, housing, safe environments, healthcare, broad-based. As you could tell from that portrayal, it really extends into and through and well beyond health and healthcare to encompass social determinants, environments where people live, work, and play. Next slide, please. So what is the HOPE initiative? What has been with us for our company for the last 4 years plus? So in a succinct way to capture it is, HOPE provides a new opportunity and approach in actionable data. When we say new opportunity and approach in actionable data, it's really important to understand that our belief from the get-go, from the start, is it's a different way to cast the approach to addressing equity with and across states and the nation. And the idea here being, as you'll see, is to consider, honor, and integrate the perspectives on disparities that have been so vital to informing action, but also take it well beyond that to consider the actionable approaches that might be undertaken. So it's a new opportunity to approach actionable data to help our nation states move beyond measuring disparities to spurring action toward health equity. And action is very much a part of it. The partners, as I mentioned, the Robert Wood Johnson Foundation has been with us from the inception and carried us through all these years. The lead investigators, Gail Christopher, it's really a cooperative, collaborative effort across the National Collaborative for Health Equity in Washington, D.C., led now by Gail Christopher, and the progenitor was Brian Smedley, who really did get this whole project started with and through his colleague work with us, and certainly through Robert Wood Johnson Foundation. I've been a co-investigator, and Nadia and I have worked hand in glove on this project, along with other great staff that have been instrumental in making it a success that it is. Derek Chapman has been representing Virginia Commonwealth University, and Steve Wolf was also someone who was involved with this project from the beginning as well. And the National Advisory Committee, led by David Williams from the Harvard T.H. Chan School of Public Health, and a number of other folks who, if you wish, you can go online and look at who's been involved with this project. Next slide, please. So as we go about the dissemination of our work, what's been instrumental and fundamental to getting word out about the potential and the content and the framework and vision of this project is our new interactive data platform, which is just a few months old, using data that Nadia will get into in more detail, but framing it in a way that is intended to be user-friendly and is a way that offers both a look at where a state such as Georgia stands within this this framework, as well as a key opportunity to compare Georgia to other states across the country in its region, and by so doing, offer reference points that we'll get into. Phrases, you'll see phrases like distance to goal, that we can look at where Georgia stands, and by the actual circumstances that extant in other states, Georgia can say, gee, could we get to this other state? And those are some of the measures that will that are part of this, and Georgia that will also be described about Georgia. The other aspect of what we're doing here is New England Journal has taken keen interest in the launch of their Race in Medicine initiative. They have integrated our HOPE data focus into their Race in Medicine project. And so through the New England Journal of Medicine, you can also access the information and the measures that we use. Next slide, please. So there are lots of really important sources of data, sources of information out and available to you. We have been well aware of them. We actually, a number of the representatives from these organizations are part of our advisory group. And so we've kind of worked in crossing communication with these groups. But in so doing, we also recognize what are the distinct characteristics of this data set, of this approach of the vision of hope that distinguish it from other very valuable sources, and at the same time provide a different perspective that may be of particular interest in what may be vital to you as you pursue your work. And I'll just raise 5 points here. Providing a starting point on the journey to achieve racial health equity. It's important to realize that a lot of data sets do not start off with racial and health equity as their at the inception. They integrate it in. It is a part of their project or a part of their effort. What we did was, from the very beginning, racial and health equity became the epicenter of the project, and everything from that, everything related to it, basically radiated out from it. So in developing and presenting what we have here today, and developing what we did, it's important to keep in mind that racial and health equity were at its core from the beginning and remained and throughout and permeates the work that we do here. Rethinking disparities and inequities to consider what's possible. So it's important, again, in the context of aspirational work, in the context of looking at what could be done, rather than just saying, well, this is a problem for us and let's see how we can deal with it. It's recognizing the problem, but also making it in tandem with what could be done to advance equity. That's also, when we talk about equity, I think it's really important to recognize that, and Nadia, I think will bring this forward too, to some extent, that equity, while it's racial and health equity, it's also keeping in mind that its impact affects all. And you'll see some commonalities, some considerable commonalities that in some ways transcend racial and health equity, but point out within them differences that are worthy of particular consideration. Third point, identify similarities and differences in opportunity and health across groups with implications for shaping programs and policies. So you'll see again where there might be opportunities by what the data say to narrow in on certain data, certain groups with the data, and with programs and policies that would be related to it. And then it's grounded in social determinants, as I mentioned. And as we think of what's happening with the efforts under the that will, I think, be front and center in the Biden administration, new opportunities to advance equity will be important as well. Nadia? So 4 fundamental features, just I think that kind of encapsulate and summarize what I've been discussing and presenting here. It's centered on health equity. Hope is centered on health equity to design data measurement that are centered on equity. Opportunity frame, instead of deficits and disparities solely, it's a focus on opportunities for all. Setting hope goals that are aspirational yet achievable, and you'll see more about that in Nadia's presentation. Then distance to goal means how far is Georgia from certain goals that it would like to achieve that other states have achieved. So less so than Healthy People 2020, where these goals are set for the country. These are living, breathing levels that Georgia could work to achieve. And with that, I will hand it off to Nadia.
Thank you, Dennis. So I will walk through what HOPE measures and what's included in the data set, and really what the data tell us about equity in Georgia. So the HOPE initiative includes 27 indicators that capture the conditions of health that are modifiable by policy and action. And you'll see laid out here are the 5 key domains. We include health outcomes. These are broad measures of health, wellness, mortality that really span the life course. You'll see infant, child, adult measures throughout. Then we've got 21 measures of social determinants of health. These are socioeconomic factors such as livable income, affordable housing, and so forth. We've got a set of community and safety factors, physical environment measures that include food security, housing, and then access to health care. And it's important, there are a couple of points I do want to point out in terms of the framing of these measures. First and foremost, the development of HOPE's frame and the measures that were included really build on the social ecological model. There's many out there. Ours really builds upon the World Health Organization framing. The second is health behaviors have been intentionally left out of the framework. And that is because too often when health inequities are discussed, racial inequities are discussed, they're so often discussed in context of personal responsibility and personal choices. And that's not the narrative that we want to advance. And we also recognize that there is a need to move beyond that personal responsibility narrative to really address the root drivers and root causes of racial health inequities. In particular, recognizing that the choices people have, the decisions that they are able to make around healthy eating, around access to care, and so forth, really depend on the conditions and the policies within which people live, learn, work, play, and so forth. So that's another key point. And then the final I'll make is these are all pre-pandemic data from public data sources such as the Behavioral Risk Factor Surveillance System, American Community Survey, National Vital Statistics System, and others. And so while these are pre-pandemic numbers, we recognize that these inequities and the magnitude of inequities that we're going to see likely persist, if not have further been exacerbated by COVID-19. And so really raise the relevance and urgency of what you're going to see. So what does HOPE tell us? Well, HOPE provides a roadmap and actionable data to help national and state leaders chart a path for achieving equity and opportunity in health. As we shared, there are 27 indicators, conditions for health that are included. These data are available by population group. So if you go onto our website, hopeinitiative.org, you'll see the interactive graphics are available by race, ethnicity for the nation and all 50 states. And then we've also got downloadable data available broken out by income and education. And as you'll see, this is kind of a one-stop shop to be able to access a broad spectrum of data for all the broad race ethnic groups that we have included, along with at the state level and at the national level. Now, kind of what I'll walk through are 4 key data points that emerge from these data, 4 ways to use the data. Number 1 is it helps identify equity gaps. Number 2, we're going to walk through the HOPE goals. So it helps, the HOPE initiative helps set equity goals for our nation, states, and communities. And then we don't stop there. We really help you take that next step to understanding, well, what will it take for our state to achieve these equity goals? What are we talking about in terms of the number of lives or people's opportunities improving to achieve those goals? And the 4th is, where do we begin to really be inspired, moved to take action toward achieving equity? So as mentioned, first and foremost, these data help our nation and states understand and identify how different racial, ethnic, socioeconomic populations are faring on opportunity and health, how wide gaps are. So what is the magnitude of these inequities that we're seeing by population group? Who's really most affected? Who's doing well across states and seem to be most advantaged systemically across the board, across the different social determinants of health? And what are the groups that systemically continue and persistently face inequities? So these are all the kinds of questions that these data help answer. The second is then, once we've identified where inequities exist, how wide these inequities are in health as well as in opportunities, then the HOPE initiative helps really identify, well, what are those aspirational but achievable equity goals across these 27 indicators. And we call them achievable because these have been set based on the average of best rates that have been achieved across the top 5 states by high-performing socioeconomic groups. And so these equity goals, it's really important. They're based on education and income and not on race. So we're not holding any racial ethnic group, not the white population, not any others as a norm. And this was very intentional, not to reinforce any kind of model minority myths or to reinforce white populations as the norm, because they too are facing, in some cases, in parts of rural America, challenges as well. And the third reason is really we wanted to base these on modifiable factors. So education and income are in fact modifiable factors. So again, these are achievable. These are evidence-based equity goals. And they're aspirational because we know that communities, states, many people have a long way to go in this country to achieve those same outcomes that high-performing socioeconomic groups are achieving across the country. And finally, these goals can be applied at any geographic level. While our data for the HOPE initiative are available at the state and national level, the actual benchmarks can be applied at any level. Third, as mentioned, then we also include what we call distanced goals measures. And you'll see what this looks like for Georgia. But what this helps us understand is how far do we have to go from the current gaps to achieving those equity goals? How many lives, again, are we going to improve? Opportunities are we going to improve for? And so these measures are provided overall. They're provided by race, ethnic groups, socioeconomic groups, again, for the nation and our states. And then the fourth is then really now, once we've understood the gaps, how far we have to go, well, how do we begin to take action? HOPE helps us identify where bright spots exist within the state. So it may be that inequities are narrow in some areas, and there may be ways to learn from within the state. What were those conditions, policies, and programs that enabled the narrowing of inequities? In other cases, there's the opportunity to learn from bright spots across the country and learn from their efforts, policies, programs that have enabled the closing of equity gaps. And really then inspiring evidence-informed actions. So moving into Georgia's data then, what does HOPE tell us about Georgia? Well, first and foremost, if we start at the distance to goal measures and we apply the equity goals, here's really the opportunity for Georgia. According to HOPE data, if all Georgians have the same opportunities as those with the best outcomes in the nation, so achieving our equity goals, we know that 3 million more would live in neighborhoods with low poverty. 2 million more would live in households with a livable income. 2 million more would have food security. 1.7 million more adults would be in excellent or very good health, and nearly 16,000 more adults, 25 to 64 years old, would survive each year. These are huge numbers in the millions of the current missed opportunity and the costs that inequities are currently having in the state of Georgia. And so if we really work to move the needle, this is what a society, a better society, and a better Georgia would look like. How many more people would really see improved opportunities? But as HOPE shows, the reality is much different currently. Health and well-being vary profoundly by race, ethnicity, and socioeconomic status. And what you see here are HOPE rankings across the 5 domains. And our rankings are based on 2 measures: the distance to goal, how far it will take to achieve the HOPE goal, and how wide racial inequities are. So it takes both of those into consideration, not just population health, which is what many of the other rankings provide. And so as you'll see, based on this, Georgia ranks in the bottom half of all states on HOPE's indicators for health outcomes, physical environment, and access to health care. And it's doing all right, somewhere in the middle for social economic factors, community safety factors. So considerable room for improvement, both in terms of population health improvement, as well as closing equity gaps. And so I'll walk through just examples of some specific indicator level data to give you a sense of what's incorporated in HOPE and what these data look like for Georgia. So the first example here is infant mortality rate, or the number of infants who die before their first birthday annually per 1,000 live births. The current rate in Georgia is 7.2. The HOPE goal, again, these are outcomes that have been achieved across the country. The best outcomes we know that have been achieved is 2.5 infant deaths per 1,000 live births. To get there, the state would need to really work to improve and ensure that over 600 more infants are surviving to their first birthday each year in Georgia. And so onto the right-hand side, what you see are the data by race ethnicity. First is Georgia, then just for sake of comparison, we've included two neighboring states, Alabama and Florida in the South, and then two states that are doing relatively better on this measure compared to all other states, California and Washington. They still have room for improvement, but as you can see, those two states are still doing a lot better than Georgia and the other southern states. And so as you see, these inequities are incredibly wide. Black and Native American infants have an infant mortality rate in Georgia that is more than 4 times the HOPE goal and higher than all other infants in the state. Also important to note that even the populations that seem to be doing relatively better within Georgia still have a distance to go to achieve the HOPE goal compared to their counterparts in some of the other states. The next example that we have is another health outcome, adult health status, a portion of adults who say they're in excellent or very good health. Currently, 47% of Georgian adults are in very good health, whereas the HOPE goal and what we know some of our top states are achieving is 73% of adults with very good or excellent health on average. The distance to go, really, we would need to see an improvement in overall health for 1.7 million more Georgians within the state. And you see what the breakout looks like, where there is considerable variation and a great distance to go by race ethnicity. Now, one point that I want to raise here really is the data for Hispanic Latino adults in Georgia, where they are not only faring worse on this indicator than all other racial ethnic groups in the state, but they're also faring more poorly than their counterparts in other states. And so this indicates really that systemically there's a need to address this, but also perhaps a need for more tailored solutions and interventions as well, recognizing that Hispanic Latinos are doing poorly just in comparison to everyone else, all other Hispanic Latinos across the country, as well as other groups within the state. Then we've got an example here of a social determinant of health. So income is one that we've chosen to share. This is a portion of adults living in households with income greater than 250% of the federal poverty level, what we consider as an absolute minimum required to really ensure sustainable living. And so 58% of Georgian adults live in households with a livable income. The HOPE goal is 88%. Getting to that goal would mean really improving opportunities for a livable income for more than 2 million Georgians. And then again, you see the considerable variation on the right-hand side and just how far each group has to go to achieve the HOPE goal. In this case, we see that Hispanic, Native American, Black adults in Georgia face the greatest barriers to achieving a livable income. Now, the third takeaway, so that was really just showing how wide the variations are by race, ethnicity. The third takeaway is what we find consistently and persistently across the board is that racial ethnic groups facing the greatest systemic barriers to basic life opportunities, so access to food, housing, income, education, are the ones who are facing the poorest health outcomes in the state. So you see here, we've got on the left-hand side, adult health status charted again by race, ethnicity. And then on the right-hand side, we've got the different determinants of health from a housing measure to income to access to low poverty concentration neighborhoods to coverage. And very consistently, in particular in Georgia, we find Hispanic and Black Georgians really facing some of the greatest barriers across the board. Now, there are some indicators, such as food security, where inequities are narrow, but it's not one that we ought to be proud of because we're finding that all Georgians have a great distance to go to achieve the HOPE goal compared to their peers. So if you look at Georgia here, it is incredibly far from the HOPE goal compared to all others, even the Southern peers. And while everyone is clustered together, it's because systemically there seems to be some kind of a gap in opportunity here. And we measure food security based on portion of people living in census tracts that are not considered food deserts. And so really an opportunity to improve circumstances for more than 2 million Georgians on this measure. And so the fifth takeaway is that systemic investments to achieve HOPE's equity goals and opportunity and help can help lift the boat for all Georgians, and especially for people of color who have long endured the effects of systemic racism. And so we've got some sample measures here. You're familiar with the distance to goal measure now, where, you know, if improvements are made to ensure that people have access to low poverty concentration neighborhoods, that would mean, you know, the improvement in opportunities for 3 million more Georgians. And you see the breakout then by race, ethnicity. We're talking about very large segments of the population benefiting if this was really tackled head on and systemically. Similarly, you see the same plays out with livable income, as well as addressing broad population health improvement. And so how can this data really inform state action for health equity? As Dennis shared, you know, one of the unique features is really equity is center, front and center of this effort. That's where we started this initiative. And so HOPE, beyond the data, really provides a new way to frame and communicate equity priorities, in particular in this extremely divisive rhetoric and society we're living in at the moment, to advance bipartisan advocacy and policy change. So it moves the narrative from deficits and disparities and from people themselves to building opportunities for all to thrive, to building systems. It's about the systems that have been, you know, inequitably created. This is based on, you know, just the long history and deep history of systemic racism. And it's about time now to really address those opportunities, those root causes of social determinants of health, to where we're creating opportunities for all to thrive. It recognizes the interconnectedness of people's health, you know, similar to what Dr. Kamara Jones says, that inequities really sap the strength of all of society. And the pandemic has really shown this very clearly, that my health is connected to yours and yours to mine. And so HOPE provides a way to frame inequities and the inequity conversation around opportunity and really improving opportunities for all. And it shows what's possible and what a society could look like if we were to achieve equity. I won't spend time on this, but it provides a starting point to really begin the equity journey, mapping those gaps, then setting goals, then measuring what it would take to get to the goals, and then really beginning to understand, well, how can I learn from other states that are doing better than I am? Another point that Dennis had raised earlier was the ability to identify common and distinct challenges faced by racial and ethnic groups to inform policy solutions. So our data by and large indicate kind of three patterns of equity gaps that emerge and the kinds of then and levels of action that are likely required from there. The first is, narrow gaps, which mean that everyone is doing well. Well, we haven't found any measure yet in our HOPE data, unfortunately, that tell us that Georgia is really doing well in terms of equity. The second scenario is where there are narrow gaps, but everyone is faring poorly. This was the case that we shared around food security, where everyone was lagging on this indicator. And so level of action, this indicates that there's likely a need for some kind of broad systemic examination and policy change that may be required to benefit all, large numbers of people in the state. And then the third, and this is by and large where the HOPE data have centered for Georgia, are that there are wide gaps. Some people faring well and some faring poorly. And you can see where some of those patterns emerge. But what this indicates is there's likely a need for both some kind of broad systemic policies as well as tailored population-specific programs and solutions. And so the bright spot states that we talked about, the ability to learn from others, to understand what are those policies and conditions that have enabled the achievement of better outcomes for opportunity and health. I have some examples here. Livable income is one, where many states with the narrower inequities and better performance are the ones with higher state minimum wage rates than the federal rate. Something new that I learned, I didn't realize that Georgia's state minimum wage rate is lower than the federal rate at $5.15 an hour, whereas there are many other states, the blue ones right here in darker blue, that have been set above the federal rate. Food security, those states that have really narrowed gaps are ones that have initiated fresh food financing programs. Health insurance coverage and healthcare access, states doing well with narrower inequities are the ones that have very proactively expanded Medicaid. And then, on the low poverty concentration measure, for example, incentivizing inclusionary zoning is a strategy that some of these states with narrower inequities have adopted. And finally, I'll close by saying that, COVID-19 has really laid bare racial injustice and inequities that exist in our society. And so HOPE really provides an opportunity to help states contextualize some of these data and help inform longer-term recovery, response, and rebuilding priorities from an equity lens. Our health affairs piece, I've got a link here that came out over the summer last year, provides a framework to apply HOPE for that purpose. And then we also just released a Texas brief as well that takes on that same approach, really helps state leaders and advocates understand, well, why are we seeing these wide inequities, and what are some of those broader systemic policy solutions that can really help us move beyond this narrative going forward. Again, acknowledging our collaborative team who have been just essential to the work of the HOPE initiative across the National Health Collaborative, our team at Texas Health Institute and VCU Center on Society and Health, and then our contact information. I'll go ahead and open it up for questions. I'm taking a moment to just open up the chat because I see some questions have come through.
Nadia, it's Carmelita. I can certainly help you with that if you'd like.
Sure, absolutely.
So the first question is, I wanted to get your opinion whether it will be better to use state and rural urban specific poverty lines rather than the FPL to determine target income?
Yep, that's a great question. And so, you know, we used FPL, again, given the scope of our work, which was federal and state in focus, but we realized that, you know, local just standards of living and cost of living really affects how far your income can go. And so while we use federal poverty level, it might be that in more local circumstances, you know, taking other factors into consideration will be important to developing, well, what is actually a sustainable, livable minimum wage for our community? So hopefully that answers the question. Dennis, I don't know if you had anything else to add to that.
Only that we have had interest from some rural dominant states to look at our information. So we believe that it has the potential, notwithstanding this kind of qualifier, to be considered in that context. You know, it's not urban dominated, solely urban dominated, that it has that potential for application in other less urbanized states.
Next question is, how do you see the public health field addressing the distrust within the Black community, especially in gaining the Black community's trust in taking the COVID vaccine?
Well, I'll start that. That's something that our Texas report at least acknowledges as a major concern. And it's interesting it comes up because I was just interviewed by the Texas Tribune in Austin about this. And this is an old issue that comes up in circumstances where public health, for example, and in this case in particular, needs to get a message out that the idea of people who are not connected to the community to speak about vaccine acceptance and uptake is likely to be compromised, that you have to find people in communities. In fact, I think what would be even better is people who have confronted this and resolved positively the issues around vaccine uptake and say, you know, look, I went through this myself. I'm in your community. I live here. I know you or know of this world, and it's important. So to have people say, this is somebody who I understand where they come from, and they're not somebody from the outside speaking to it. And I think you know, Hope doesn't get into the specifics of trust, but the implications behind the data that are considered within Hope are rife with the presence of needing to reach communities. And to us, a lot of the work we've done on equity, and as I said in the COVID-19 report, really kind of touch on that directly.
And Nadia, would you like to address that question as well? Thank you so much, Dennis.
Sure, absolutely. I would just add, you know, and Dennis mentioned this, just the importance of community and engaging community-based organizations, those anchored within communities that are trusted, faith-based organizations, you know, ethnic, civic groups as well. Really the importance of engaging and working with them. And what we're working with some state partners on is, and what's been a missed opportunity is in public health, it's all about relationships. And those relationships, you know, don't start now. They should have been in place well before. And so to what degree can we really leverage and build on existing strong health, public health and community relationships to really build on and build trust around vaccine. And the delivery then also of communication and information through these trusted partners in culturally and linguistically appropriate ways, through trusted channels, through trusted champions, all of that level of infrastructure that I think some states are really working to build where there is will. And some of our states, unfortunately, Texas is one of them, and others in the South, where it's been a little harder to build that community partnership and infrastructure and really prioritize the importance of communication and working through trusted channels and partners and investing in those priorities.
I'll also give you one concrete example before we leave this topic, because I think it's really important, although it's related to, not directly, but it's indirectly related to our work on HOPE and certainly on COVID. When Nadia and I were in Philadelphia, I was at Drexel University, and we were engaged in a major effort on emergency preparedness and response, especially for diverse communities. And at one point I went to the health department and was talking with them about their efforts to reach populations and to impress on them the importance of preparedness and response to pandemics, to floods, to other circumstances. And they said, when we go out to communities, we talk to them about these issues, and the responses we get are people would come up to me afterwards, in this case, a public health official, and say, yeah, I was listening to you about this preparedness priority or importance. And said, but I've got problems with my diabetes medication. Could you help me with that? Well, that is so grounded in the day-to-day challenges that folks face that other issues may seem abstracted. There are things that are affecting, there are challenges that are affecting people directly. That's the way to reach the populations, the individuals in need, is that you may have to go there indirectly by saying, yeah, let me link you up and gain your trust in that way, that as a source. And maybe then after that, other connections will follow. So there may be an indirect course to gaining that trust, especially from public health officials, that I think needs to be kept in mind as we proceed with vaccinations as well. And communication strategies, which are vital, how the communication strategies are really tailored to communities.
Thank you, Dennis. The next question, and I'm trying to make sure that we get through all the questions, so I'm moving quickly. I'd like to know more about the data being utilized for the HOPE initiative. For instance, I don't see any indicators related to transportation equity, accessibility of mass transit, walkability, neighborhood connectivity, etc. Additionally, understanding levels of power that communities have are critical to address equity, voter registration, participation. What is the possibility of adding those kinds of data?
That's an excellent question. I'm happy to take that one. Again, when we started down this path, we started with a very large list of indicators. I want to say we had over 75 indicators that we were considering. Over time, we whittled it down based on for many reasons. First, we were applying the social ecological model, and so we really wanted to be sure the alignment of metrics with research, with the model, with and them being evidence informed. Second, though, availability of data by state, by race, ethnicity, and making sure that uniform data and metrics were available, at least by the 6 OMB categories of race, ethnicity. It really came down to that availability of racial ethnic data at the state level, reliable data that could be available across the board. That whittled down many of these measures. And then the third was we came down to certain areas that were critically important, but we just didn't have the right measures for them. And you point that out. Civic engagement is one, social connectedness and others. And so HOPE is not intended to be static. It's not a static effort. I think in its future kind of phases and efforts, we would like to incorporate and more fully capture the broader social determinants of health. That includes what you mentioned around transportation, but also critical, important community measures around civic engagement, everything else you've laid out. So thank you so much for that question.
I would also add that on state and sub-state efforts that would be interested in incorporating hope, there's nothing that prevents states or communities to use the framework and the vision and the data to integrate other measures that could inform priorities in those areas.
Thank you, Nadia and Dennis. Next question, cross-sector alignment is critical for moving the needle on these issues. In Texas, who are the partners at the table for the HOPE framework implementation outside of traditional public health partners? Is private sector involved, other public partners?
We have a sister project with the Robert Wood Johnson Foundation where we are evaluating cross-sector alignment across Texas. We're evaluating 24, up to 24 such initiatives across the state. Much of the work right now within the state has been local and regionally focused, as opposed to statewide. And so one of the things that we're looking to do at the Institute is to see how can HOPE provide a framework to offer, some kind of benchmarks for all regional cross-sector collaborative initiatives to begin to work toward to move the needle on equity, because we realize there's such rich and great work that's happening at the local level, but that the impact is limited to the local level and doesn't then disperse out to other parts of the state to where we're beginning to see, state improvement in health outcomes and equity. So that's one important way we're really looking to leverage the HOPE data. Now, regionally and locally, these cross-sector alignment initiatives look very different. In many cases, they are public health, healthcare aligning with social service sectors. So you have food banks. If the focus is around food security, then you've got food banks involved, in some cases, retail involved. It just depends on what the focus of these cross-sector efforts is and who's involved. But we're seeing a lot of movement toward alignment of health, public health, social service, plus even the private sector.
Thank you, Nadia. Next question, food deserts are often used to measure food insecurity, but the programs that we have initiated, such as farmers markets, do not show up in the food desert picture. What other measures have you used or would recommend using that would give a more complete analysis to investigate food insecurity?
That's a great question. And I'm going to be honest, I'm not sure I have the answer off the top of my head, but I am part of a collaborative that's working to address food insecurity here in Texas. So happy to connect. Perhaps if you want to send over some information, I'm trying to see who asked the question, but we can connect and I can send some more information on that following this meeting.
There's somebody at the THI who specializes in
yes.
food issues, and so we'd be happy to follow up.
Thank you, Nadia. I can certainly send you this question if you don't see it in the chat. Are there any other questions? This one just came in, community and safety factors. Have you reviewed the police type attached to these areas? For example, community policing, school resource officers, etc.
That's such a great question. We have not, and this is one of those areas, again, it's one of the domains and areas where we feel we could continue to build on and improve the set of metrics. It really comes down to availability of data. And so the more we can identify and continue to build this out, I think the better to capture the kinds of questions you're raising.
Thank you. We have 5 more minutes remaining before we go back to our general session. Are there any other questions or comments? These last 5 minutes.
As people think about that, we have a question to attendees. Is there, we would love to get your sense or response, first thoughts, first impressions of what we presented. If anybody would like to bring that up, we would welcome your comments.
And everyone can use the chat to place those comments.
Are you just so awed by our presentation that people are speechless?
Well, Grace isn't speechless. She says the most important aspect of the framework that stood out to me was leaving out the behaviors. And I really appreciate the acknowledgement of that for systems change.
Yeah, much of what we've tried to feature is, while it touches and recognizes the importance of program-specific priorities, it also really is intended to look broadly, systemically at what is happening within states that are venues for opportunity, using data in a positive way. And it's interesting, I had an opportunity about a year or so ago as we were developing this HOPE project to present data before the Department of Health Services in Texas. And the comments that came back were around the people in the department saying, we had never really had an opportunity to look at the issues we face from this perspective. So we were used to looking at it in context of disparities. We were used to looking at it in terms of deficits. But your approach turns that around, turns it almost on its head and says, well, look, you not only can you look at the more aspirational aspects that are grounded in reality, but also look at what works and what could work better and what is not working well within a state. So it affords the opportunity to say, gee, we're doing some things that are interesting here that we can see can be recognized by by HOPE. And then we can also see other ways in which we need to move to a better place. And then also it's important to stress here that our approach, playing to the systemic aspect of this, our approach is encompassing. So it's not just racial ethnic groups, it's the society, it's the residents of a state that by the nature there may have more common ground than people may realize, while at the same time acknowledging that certain groups within a state have distinct challenges.
Well, I would like to thank everyone for attending this presentation, and thank you so much for that, the presentation. It was definitely something to think about, and we are so glad that you came to our State of Public Health. So we'll be taken back to the general session for our spoken word artist and closing keynote speaker, Dr. Renee Kennedy. Thank you all so much.
Thank you for the opportunity.
Thank
Good day.
you so much for the opportunity. Thank you, everyone.